Imagine you're driving down a high-speed interstate, right?
Okay. Okay.
And you're on a tire that has just been patched after this like massive blowout.
That is a terrifying thought.
Right, it's terrifying. You are suddenly hyper-aware of literally every single bump in the road, every slight vibration in the steering wheel.
You'd be gripping that wheel so tight.
Exactly, because if you just keep driving at, say, 80 miles an hour, the sheer centrifugal force of that spinning wheel is it's gonna rip that fragile patch right off.
Yeah, the physics alone would destroy it.
Exactly. So the only logical way to survive the rest of that trip is to, drastically reduce your speed.
And when we map that imagery onto human biology, we are looking at the exact literal mechanical reality of a survivor who has just suffered an intracerebral hemorrhage.
The brain bleed.
Right, a brain bleed. A blood vessel has ruptured directly into the brain tissue.
Wow.
So the patient survives that initial catastrophic blowout, but that healing vascular tissue, that patch, so to speak, it remains incredibly delicate.
So the speed has to come down.
Exactly, the systemic speed, which in this case is the blood pressure running through those vessels. It has to come down. Or a second, potentially fatal rupture is, well, it's almost a mathematical certainty.
Which brings us to today's topic. Welcome to the deep dive, everyone.
Glad to be here.
We are unpacking a genuinely practice-changing study today. This was published in the New England Journal of Medicine, dated April 23, 2026.
It's a huge piece of literature.
It really is.
Yeah.
And our mission today is to look at this formidable medical challenge, preventing a recurrent stroke after one of these brain bleeds.
And the source material points to a really fascinating and highly counterintuitive premise.
Yeah, counterintuitive is the perfect word for it. Medical researchers have basically figured out how to dramatically reduce that secondary stroke risk. But the treatment itself requires navigating this crazy physiological tightrope.
Right, a tightrope that actually forces a pretty significant percentage of patients to just abandon the medication entirely.
Which is wild. But before we get to the catch, let's talk about the stakes here. Why is this so hard?
Well, the stakes for this specific demographic are just immense. I mean, historically, lowering blood pressure has been our singular proven defense.
It's the only tool we've really had.
Exactly. We know we absolutely must reduce the mechanical shear stress on that delicate microvasculature in the skull.
The pressure on the patch?
Right. But the persistent clinical failure over the decades, it hasn't been a lack of understanding the goal. We know the goal.
It's the execution.
Exactly. It's a lack of tools to achieve that baseline pressure drop consistently, without causing secondary organ damage somewhere else in the body.
So the study we're analyzing today tests a completely novel intervention to try and solve that exact problem.
A totally new approach.
Yeah. Instead of the standard stepwise medical care, where you basically give a patient a drug, see if it works, and then aggressively just up the dose.
Which is a standard playbook, yeah.
Right. Instead of that, researchers introduced a single triple pill.
The triple pill.
Yeah, it's a combined capsule. It contains 3 distinct blood pressure medications at highly, highly reduced doses, and you take it on top of standard care.
And we need to really look closely at whether this microdose cocktail actually provides, superior physical protection for the brain.
Because it sounds almost too simple, right? But to appreciate why combining 3 drugs into one low-dose capsule is such a radical departure, we really should look at that traditional medical playbook you mentioned.
Right. So typically, if a patient presents with elevated blood pressure, a physician prescribes a monotherapy, one drug.
Right, one drug.
And if the pressure remains stubbornly high, the standard protocol is to just crank up the dosage of that same medication to its maximum tolerable limit.
Which, to me, is essentially a sledgehammer approach.
That's a great way to put it.
Right. You are relying on sheer brute force from just one chemical mechanism. But swinging a pharmacological sledgehammer inside the human body, it causes massive systemic collateral damage.
Absolutely. The patient experiences dizziness, severe fatigue, maybe a racing heart. It's rough.
It sounds miserable. So this triple pill approach, it feels much more like deploying a coordinated tactical team.
A tactical team. I like that.
Yeah, you have 3 distinct specialists, right?
Yeah.
They're sent in to dismantle the hypertension from completely different angles, using absolute minimal force.
The tactical team concept perfectly captures the pharmacological strategy the researchers designed here.
Okay, so who's on this team? What are the ingredients?
So they combined 3 very established antihypertensive agents. You've got telmisartan at 20 milligrams,
Okay.
amlodipine at 2.5 milligrams, and indapamide at 1.25 milligrams.
Wow, those numbers sound really small.
They are. Those dosages are merely a fraction of what a physician would typically prescribe for a standard monotherapy.
Now, looking at those three specific drugs, my instinct is that they must be targeting completely different, operating systems within the body.
They have to, Boo.
Right, because if you administered three drugs that all triggered the exact same biological response, you wouldn't be gaining any tactical advantage at all.
No, you'd just be swinging 3 smaller sledgehammers at the exact same wall.
Exactly. So how do they work?
Well, they operate on entirely distinct physiological pathways. And that is the absolute key to preventing the body from relying on its natural compensatory mechanisms.
Okay, break that down for me. Start with the first one, the telmisartan.
Sure, so telmisartan is an angiotensin II receptor blocker. It directly interrupts the renin-angiotensin system.
Which means what exactly for the blood vessels?
Well, angiotensin II is a really potent hormone. It basically commands your blood vessels to constrict, to squeeze shut.
Oh, I see. So it drives the pressure up.
Exactly. So by blocking the receptors for that hormone, the telmisartan allows the vessels to remain wide and relaxed.
Okay, so that neutralizes the hormonal constriction. That's specialist number one.
Right. But amlodipine, the second drug, tackles a completely different mechanism.
The muscles, right.
Exactly. Amlodipine is a calcium channel blocker. It targets the smooth muscle cells that physically wrap around the exterior of your blood vessels.
Like little bands.
Yeah, exactly like little bands. For those muscle cells to contract and squeeze the vessel shut, calcium ions actually have to enter the cellular channels.
Okay.
Amlodipine physically barricades those calcium channels, so that drastically reduces the vessel's mechanical ability to squeeze tight.
Wow, so you achieve direct muscular relaxation of the vascular walls.
Precisely.
Okay, so now we have hormonal relaxation from the first drug and direct muscular relaxation from the second. What about the third component? Indapamide.
Right. The indapamide is a diuretic. That shifts the actual fluid volume inside the pipes.
So it's dealing with the liquid itself, not the pipes.
Exactly. It essentially prompts the body to let water out of the system. So there is physically less liquid pushing against those vessel walls.
That makes total sense.
That is the third prong of the coordinated attack. Indapamide is a thiazide-like diuretic that literally forces the kidneys to excrete excess sodium and water.
Physically reducing the total blood volume.
Right. And here's the really brilliant part about combining them. When you use just one of these drugs at a high dose, say, only the diuretic, the body immediately registers that sudden drop in fluid volume, and it panics.
It freaks out.
Totally freaks out. It interprets that drop as dehydration, or worse, bleeding. So it compensates by releasing massive amounts of that hormone, angiotensin, to forcefully constrict the vessels and drive the pressure right back up.
Oh, so the body inherently fights back against the sledgehammer. It tries to undo the medication's work.
It fights back vigorously. But when you deploy the triple pill, you actively block that compensatory reflex.
Because the other two drugs are already there.
Exactly. You reduce the fluid volume with the diuretic, and when the body tries to constrict the vessels to compensate, the amlodipine and telmisartan are already stationed there.
Blocking the muscle contraction and neutralizing the hormones. That is brilliant.
It is. You achieve a synergistic drop in systemic pressure using very low doses, precisely because the multiple pathways prevent the body from mounting a defense.
Now, that level of biochemical coordination, it makes perfect sense on paper.
It does.
But human biology is notoriously chaotic, which means the researchers had to actually prove this tactical team functions long-term inside a living patient.
A patient who has already suffered catastrophic vascular failure, no less.
Right. So let's look at the architecture of the trial. How did they test this?
The methodology they utilized to prove this efficacy is incredibly rigorous. The trial was multinational, double-blind, randomized, and placebo-controlled.
The gold standard.
Absolutely. They enrolled 1,670 clinically stable patients, and all of them had a documented medical history of intracerebral hemorrhage.
Now, looking at the study, one specific demographic detail immediately jumped out at me from the baseline data.
The age.
Yes. The average age of the participants was just 58 years old.
It's sobering, isn't it?
It really is. People often associate a major hemorrhagic stroke with advanced age, perhaps someone in their late 80s.
Right.
But 58, that is a person in the prime of their life. They're likely still navigating their career. They have decades of cognitive and physical health left to protect.
Yeah, the relatively young age of the cohort really highlights the profound urgency of secondary prevention here. A recurrent bleed at 59 or 60 would be absolutely devastating.
Would essentially rob them of their later years.
Exactly. So to ensure they were testing the intervention safely, the baseline entry rules required participants to have systolic blood pressure between 130 and 160 millimeters mercury.
So they were targeting patients whose pressure was persistently elevated, but not in an immediate, acute crisis.
Right. They had to be stable.
Okay, but as I was reading through the chronological timeline of how they enrolled these 770 individuals, I hit this methodological step that seems entirely backward to me.
The run-in phase.
Yes,
Yeah.
run-in phase. I mean, my understanding of a standard randomized trial is that you take your total group, you randomly administer the real drug to half, give a fake sugar pill to the other half, and then you just track the divergence, right?
Right. That's the textbook way to do it, yeah.
But this study inserted an active run-in phase
Yeah.
for 2 whole weeks
Yeah.
before they randomized anyone.
Right. They administered the active triple pill to all 1,670 enrolled participants for 14 days.
See, my instinct says that completely contaminates the baseline,
It sounds like it would, doesn't it?
right? If your goal is to test long-term efficacy against a placebo, giving the future placebo group the real biologically active drug for 2 weeks seems like it would just drastically alter their initial blood pressure readings.
And skew the eventual comparison.
Exactly. Why intentionally muddy the water before the trial even starts?
I can completely understand why you'd ask that. It seems highly counterintuitive, but it actually elegantly solves a massive logistical problem in long-term cardiovascular research.
Okay, what problem is that?
Early dropout skew.
Oh, meaning people quitting the study.
Exactly. If you immediately randomize 1,000 people and give half of them a totally novel antihypertensive cocktail, a certain percentage will experience acute, immediate intolerance within the very first 72 hours.
Really? Like what kind of intolerance?
Well, their blood pressure might drop way too rapidly, causing severe orthostatic hypotension, which is that dangerous dizziness you get when standing up. Or they might just have an acute allergic reaction.
Oh, right. And if a patient drops out of the study on, day 4, you lose that data point entirely.
Right. You have absolutely no idea if the drug would have successfully prevented a stroke in year 2, simply because they couldn't survive week 1.
Ah. So the active run-in phase acts as a biological stress test?
Exactly. A stress test for the entire cohort. It successfully filters out the acute non-responders and those whose physiology just fundamentally rejects the pharmacological mechanics of the triple pill.
That is actually really clever.
It is. By ensuring everyone can at least tolerate that initial physiological shift, the researchers basically protect the integrity of the long-term data.
So when they finally split the cohort, which was 833 patients continuing the active pill and 837 switching over to the placebo, they knew with total certainty they were studying a population physically capable of staying the course.
Precisely. They filtered out the immediate noise.
So that filtering mechanism sets the stage for a remarkably clean data set.
Very clean.
And they monitored these 2 groups for a median of 2.5 years, right?
Correct. And remember, both groups continued receiving their standard stepwise medical care from their personal physicians.
Oh, right.
But the active group was just quietly being bolstered by this daily low-dose tactical team.
Okay, so let's get to the results. After 2.5 years, what happened?
Well, the primary outcome of the trial was the incidence of recurrent stroke, and the numbers are striking. In the placebo group, 62 patients suffered a subsequent stroke. That equates to 7.4%.
Okay, 7.4%.
Yeah.
And the active group?
In the triple pill group, that number dropped to just 38 patients, or 4.6%.
Wow. The source data provides a hazard ratio of 0.61 accompanied by a p-value of 0.02.
Right.
And if you are listening and wondering what a hazard ratio of 0.61 looks like in practice, it essentially means the triple pill reduced the relative risk of a recurrent stroke by nearly 40% compared to the control group.
40%. It's massive.
A 40% reduction in a medical event that carries an exceptionally high mortality rate. I mean, that is a monumental clinical achievement.
It really is. And the secondary outcomes provide the underlying mechanical explanation for that 40% reduction.
So what drove it?
It ultimately comes down to the sheer physics of vascular pressure. Over the extensive follow-up period, the patients taking the triple pill maintained a mean systolic blood pressure of 127 millimeters of mercury. The placebo group, on the other hand, averaged 138.
So that is an 11-point difference.
Right.
Now, on a standard blood pressure cuff in a doctor's office, 11 points might seem like a a rounding error.
Sure, to a layperson.
I mean, a person can alter their blood pressure by 11 points just by drinking a strong cup of coffee, right?
Aye.
Or getting stressed in rush hour traffic.
Absolutely. Systemically, it might appear to be a really minor fluctuation, but you have to remember where this is happening.
In the brain.
Yes. Localized inside the rigid, totally enclosed confines of the human skull. And it's acting constantly upon a blood vessel that has already suffered severe structural failure.
Oh, man. So that 11 points is just pounding away.
Exactly. 11 points of unrelenting, 247 pressure is immense. It is the literal mechanical difference between the healing vessel wall holding together and completely shearing apart.
Which explains the broader outcomes too, right? Because lowering that baseline mechanical stress resulted in lower rates of major cardiovascular events across the board.
Yes, it dropped from 9.8% for the placebo to 6.6% for the triple pill.
The tactical team clearly executed the mission.
Without a doubt.
I mean, the 3 low-dose drugs prevented the body from mounting a compensatory defense, they lowered the constant physical pressure, and they successfully protected the vascular patch in the brain.
They absolutely did.
But there is a catch.
There is always a catch in medicine.
Right. There's a physiological tightrope involved in this treatment protocol. The safety data actually presents this fascinating paradox that really requires a deep understanding of human biology to fully parse.
It's a very tricky situation.
So the study notes that serious adverse events actually occurred less frequently in the triple pill group. It was 23.2% versus 26% in the placebo group.
Right, which totally aligns with the primary outcome. The drug is actively preventing the most serious adverse events we track, recurrent strokes, massive heart attacks, cardiovascular deaths.
But the paradox emerges in the very next metric.
The dropouts.
Yes, early discontinuation of the trial, meaning a patient permanently quitting the daily regimen specifically due to an adverse event, was more than double in the triple pill group.
Double.
13.6% of the triple pill patients abandoned the medication, compared to only 6.0% in the placebo group. So the drug is highly effective at preventing life-threatening events, yet it causes twice as many people to abandon it.
And the specific physiological reason for that abandonment is outlined very, very clearly in the data.
What was it?
The primary driver forcing patients to discontinue the triple pill was an increase of 20% or more in their serum creatinine levels.
Okay, let me hazard a guess on the underlying mechanism here.
Go for it.
Creatinine is a natural metabolic waste product, right? And the kidneys are entirely responsible for filtering it out of the bloodstream.
Correct.
So if serum creatinine is rising in the blood tests, it means the kidney's filtration system is literally failing to do its job.
That's exactly what it means.
And given that we just spent the last few minutes analyzing how this drug cocktail artificially drops blood pressure, I assume the kidneys actually require a certain amount of systemic pressure to physically push blood through their internal filters.
You have identified the exact biomechanical conflict here. It revolves around the glomerular filtration rate, or GFR.
GFR.
Yeah. The human kidneys contain millions of microscopic filters called glomeruli. And to force blood through those tiny, dense biological sieves and extract the metabolic waste, the kidneys require adequate renal perfusion pressure.
Meaning they need a strong push.
Yes. They are highly dependent on the systemic blood pressure provided by the heart to maintain that driving force.
Wow. So we have an active high-stakes tug-of-war happening inside the patient's body.
A literal tug-of-war, yeah.
The injured brain is begging for a massive reduction in systemic pressure to protect its fragile vessels from rupturing a second time. But the kidneys are signaling that they don't have enough pushing force to push the blood through the glomeruli.
Exactly. The triple pill dramatically alters the intricate fluid dynamics of the kidneys.
Because of the specific drugs.
Right. You have the indapamide physically reducing the total fluid volume of the blood, and at the same time, the telmisartan actively blocks the angiotensin hormone.
Which the kidneys normally use, right?
Yes. The kidneys specifically rely on that hormone to constrict their own local blood vessels and maintain internal pressure when systemic pressure drops.
Oh, wow. So you're disarming their defense mechanism, too.
Exactly. For approximately 86% of patients, the kidneys successfully adapt to this new lower pressure baseline. They do fine.
But for that 13.6%.
Right. For them, the tactical team drops the perfusion pressure well below the kidney's functional threshold.
And when a physician reviews a routine blood panel and sees that serum creatinine spike by 20%, I mean, they are staring down the very real threat of acute kidney injury.
Absolutely.
So they have no choice but to pull the patient off the trouble pill, even if they know for a fact the medication is technically saving the patient's brain.
It perfectly encapsulates the complicated reality of clinical medicine. Pharmacological efficacy in a vacuum is meaningless.
Right, because you're treating a whole person.
Exactly. A drug can be a total mathematical triumph for secondary stroke prevention, but individual renal tolerance ultimately dictates whether that treatment is viable in the real world. Clinicians are just constantly balancing the survival of one vital organ system against the functional capacity of another.
That physiological balance is incredibly delicate. But, we cannot let the dropout rate overshadow the monumental success of the primary finding here.
Oh, absolutely not.
I mean, for survivors of an intracerebral hemorrhage, layering a microdosed combination of telmisartan, amlodipine, and indapamide over standard medical care provides a profound 40% reduction in the risk of suffering a recurrent stroke.
It's game-changing.
It really is. It successfully lowers the mechanical shear stress on the brain without relying on the massive blunt force doses that have characterized traditional hypertension therapy for decades.
It is a definitive win for cardiovascular research and clinical practice. But, looking beyond stroke prevention, the success of this trial opens up a much broader, deeply provocative conversation
About what?
about how the medical community views patient compliance across all chronic diseases. Historically, we often label patients who stop taking their daily medications as, non-compliant or stubborn.
Right. We tend to blame the patient for failing the prescribed treatment.
But this trial suggests the complete opposite might be true. Our traditional brute force high-dose titration methods might actually be failing the patient's underlying biology.
Oh, that's fascinating.
Right. If a low-dose tactical team can achieve a 40% reduction in major neurological events by working alongside the body's compensatory mechanisms rather than simply overpowering them, we really need to rethink our entire dosing philosophy.
So applying this beyond just blood pressure.
Exactly. Imagine the implications for treating complex conditions like severe diabetes, autoimmune disorders, or even psychiatric illnesses.
Wow.
If we move away from the medical sledgehammer approach and toward highly coordinated microdosed combinations, we might discover that patients aren't stubbornly refusing their medications at all.
They were simply waiting for a pharmacological regimen their biology could actually tolerate.
Exactly.
That fundamentally flips the script on how we perceive the doctor-patient relationship and long-term medication adherence. If we can get smarter about manipulating the biology, we don't have to fight the patient's own body to save their life.
A very hopeful thought.
It is. Well, thank you for joining us on this deep dive. We really hope you leave this conversation with a deeper understanding of the incredible mechanics keeping you alive and how the future of medicine might just be found in much, much smaller doses. Until next time.